Hi, I'm Guillermo Zalazar, a neurologist. I'm going to talk briefly about the vestibulospinal pathways and the vestibulo-autonomic interaction. To recall, the vestibulospinal tract are divided into a lateral and a medial tract. The medial ends in the cervical spinal cord, while the lateral descends through the rest of the spinal cord. The first mediates the vestibular colli reflex, and the second, the vestibulospinal reflex, collectively referred to as the vestibulospinal reflex. The vestibulospinal reflex are tools that allow us to move around the environment, making the necessary correction in tone and in the level of muscle contraction to avoid fall. One of the ways to evaluate this type of reflex is by causing vestibular stimuli and recording what occurs in the muscles, both appendicular and axial, through the use of electromyography. One of the functions is the control of muscle tone. For this, the vestibular nucleus integrates information from different regions, proprioceptive, visual, and vestibular signals, signal of cortical areas. Its activity is modulated by the vestibular-cerebellar interaction and interacts with the reticular formation to control muscle tone. In this way, it coordinates the contraction of flexor and extensor muscle to maintain a posture or make correction to avoid falls. When we perform BEMS in a patient with spasticity, we can observe how the amplitude of the response is greater the more spasticity they have. This demonstrates the involvement of the vestibulospinal pathway in the control of muscle tone. The vestibular nucleus interacts with the nucleus of neurons responsible for autonomic response to change in blood pressure and blood flow caused by postural change. In this way, it can cause change in blood pressure and blood flow before the baroreflex is activated by change in blood pressure. It has been observed that if the autolytic organs are damaged, the baroreflex can maintain blood pressure within normality when with change with postural change, but the brain blood flow falls, which indicate that the autolytic organs are important to adapt blood flow to postural change before the baroreflex is activated. We know that the cerebellum modulates the activity of the vestibular nuclei, so their interaction control the vestibulospinal reflex. This vestibular-cerebellar interaction modulates both muscle tone, posture, and balance. In a study we carry out the data which has not yet been published, we have found that the sample categorization of truncal ataxia in 4 grade, 0 no ataxia, grade 1 ataxia, the patient can ambulate without assistance. Grade 2 ataxia, patient needs help walking but can stand unaided. Grade 3 ataxia, the patient cannot stand without help. It can help in the differential diagnosis of acute vestibular syndrome. We found that all patients with acute vestibular syndrome have some degree of ataxia, and that grade 3 ataxia always had a central origin. When we discriminated central lesion due to compromise of the anterior-inferior cerebral artery from the posterior-inferior cerebral artery, we found that severe ataxia or grade 3 ataxia is more frequent when the ICA is compromised, which can be explained by the compromise of the structure that intervene in the vestibular-cerebellar interaction. Based on the above and considering how difficult it is to apply the HINTS protocol by emergency physicians who do not have adequate training in neurological evaluation, we propose the following algorithm to approach the patient with acute vestibular syndrome in the emergency room. It began by examining the truncal ataxia. If there is no ataxia, it can be almost certain that there is no injury. If there is grade 1 ataxia, it is most likely a vestibular syndrome of peripheral origin, but examination for nystagmus characteristic might help. If there is grade 3 ataxia, we know that we are dealing with a lesion of central origin. If the ataxia is grade 2, the nystagmus is evaluated. If it has central feature, the lesion is central. If it had peripheral characteristic, it is time to carry out a more complete neurological evaluation, applying the HINTS protocol by trained physician. The vestibulospinal pathway are involved in multiple functions. There is little knowledge about how it intervenes in postural control and the maintenance of blood pressure. And this might be because the pathway involved in these processes are more intricate. Its interaction with the reticulospinal pathway is poorly understood. Its control by higher center, such as the cerebellum, is little known. From a clinical point of view, the usefulness of vestibular signs in the diagnosis of vestibular disorder has been little explored, being relegated by the study of vestibular signs. Thank you very much for your attention.
So will we take up the questions?
We can write down the question in the chat for the speakers. No questions?
It looks like I see one question. What do you think about mild vertical nystagmus that only can be seen with video goggles? So I'm happy to address that one. So it's tough. I've seen patients who one of my neuro-otology colleagues saw 15 years ago who just had a little tiny bit of downbeat with fixation removed, no gaze evoke, no saccadic pursuit, nothing else that might indicate something central. And then I saw that patient 15 years later and they had a full-blown cerebellar syndrome. So sometimes when you see a little bit of vertical nystagmus, a little bit of fixation removed, downbeat nystagmus, and nothing else, that could possibly be the very beginning of something that's in evolution. And if you saw that patient a couple of years later, a couple of months later, you might see a lot more. I've also seen patients with sort of vestibular migraine with a little bit of downbeat, maybe when they're upright, a lot of different patterns of positional nystagmus, obviously with migraine as well. And I've seen patients who have a little bit of downbeat. They're sort of in the ictal period. They've got some migraine features at that moment. The next time I see them, migraine's under better control, or they're not in the ictal period, and they might not have it. A little bit of upbeat nystagmus, same kind of thing. You're going to look for the company that it keeps. So if there's a little bit of downbeat with fixation removed only, do they have gaze evoke nystagmus? Do they have saccadic pursuit? Do they have saccadic dysmetria? Do they have gait ataxia, appendicular ataxia, any other neurologic abnormalities that might suggest that it's more than just a little bit of a fixation removed vertical nystagmus? Remember also in smokers, patients who smoke, who just had their cigarette 30 or 60 minutes ago, sometimes that's enough to induce a little bit of fixation removed upbeat nystagmus as well. So that's been my experience. I'd be interested to hear others' experience with that kind of a patient as well. And some people, if you were to take some people off the street and they've done this, some people just have a little tiny bit of 1 degree per second upbeat or downbeat nystagmus with fixation removed only, without any vestibular symptoms.
Hi, everybody. Thanks, Dan. Sorry, I was a bit late. My name is Asif Sheikh. I was trying to connect, and there were some glitches. Regarding the nystagmus, which can only be seen in Frenzel, I have a couple of very interesting stories to share, especially the vertical and the torsional one. I strongly recommend that when you see such things, and if patient has non-specific dizziness, I would look at their palate. At least 2 or 3 times I remember when the nystagmus was very subtle, and once, actually it was Dave Z's patient I saw when I was in Baltimore. There was only very subtle torsional nystagmus, only seen on Frenzel, and there was a syndrome of oculopalatal tremor. Patient also had palatal tremor. So you always want to look at people's palate when they are coming with non-specific dizziness and when they have very subtle vertical or very subtle torsional nystagmus, because frequently there is a spectrum between palatal tremor and the ocular tremor in OPT, and we do see a sometimes very subtle palatal tremor with robust eye nystagmus, but sometimes we see robust palatal tremor with very subtle eye nystagmus. So this is one more thing I would say to add.
Absolutely, I agree.
Sorry, go ahead.
Sorry, I was going to say, I absolutely agree. Any little bit of funny nystagmus, always look at the palate. You will be surprised if you do that. Absolutely.
The other thing would be multiple systems atrophy. I would look for Parkinsonism as well in those patients, because often we see very subtle nystagmus in patients who have multiple systems atrophy. But of course, like in that, patients probably would suffer from much more in a way of Parkinsonism as well. Thank you.
Dan, may I say something? I guess I cannot put the video up.
Absolutely, we can hear you.
So that was a great presentation. Thank you. Adding the prone position testing to positional testing in cases of apogeotropic nystagmus is very important. We have found a few cases that pointed to central lesion. It's a nystagmus that comes in prone position, that is non-fatigable, and coupled with the apogeotropic nystagmus, then you probably pointing definitely to a lesion in the nodules. And we were not doing that because we couldn't really see it. You know, you have to use the goggles in order to be able to see the nystagmus. Well, that's a test that was not really done before, and now we include that in cases where there is a diagnostic question.
I agree. I've been doing it, and every single patient has sort of a screen, and pretty nearly 100% of the time, if I have a suspicion that there's something cerebellar, something central going on, I'm going to see a little bit of downbeat with prone, or if they already have downbeat, it's really going to aggravate it in a lot of patients, more patients than I thought.
Okay,